If you have Medicare and your doctor takes Medicare, why can it still take months to get an appointment? And here's the question people whisper next. Doc, can I just pay extra to get in sooner? Most people assume the answer is yes. In Medicare, though, the answer is basically no. Not because your doctor hates seniors, not because you did anything wrong. It's because Medicare has strict rules about what doctors can charge, even if you want to pay more. Let me show you how that works and why it quietly turns into longer wait times. I debated whether I wanted to film this episode, because Medicare talk can quickly turn into a comment section cage match. It can turn political. But this isn't politics for me, it's personal. Not too far from now, I'll be relying on Medicare too, and I'm grateful it exists. We paid into it for most of our working lives. My worry isn't should Medicare exist, my worry is what will Medicare look like when I need it? And even if it's still funded, what will it actually get me? Because here's what patients are already experiencing. Even if you have Medicare, even if your doctor takes Medicare, access can still be limited. And when that happens, most people assume one of two things. My doctor is greedy, or the system is broken and nobody cares. The reality is more boring than that, but it's also more complicated. So let's do a quick Medicare 101. If we don't define the terms, it's going to be very difficult for this video to make any sense at all. Medicare isn't one single thing. It's a bundle. Part A is your hospital coverage. Part B is your outpatient and physician services, office visits, imaging, procedures. Part D is for prescription drugs. And then there's Medicare Advantage, Part C, private plans that replace traditional Medicare for many people. And that matters because when someone says, I have Medicare, they might mean traditional Medicare, or they might mean they are a Medicare Advantage plan with networks and prior authorizations required. These can feel like two completely different experiences. Now let's talk about why access gets limited. There is a point where the reimbursement for a visit or a procedure does not cover the overhead required to deliver that care. And yes, somebody's going to say, well, maybe practices are bloated. Listen, some businesses are inefficient. That's true everywhere. But in medicine, a lot of the cost isn't optional. It's baked in by regulation, documentation, compliance, and the administrative machine that has grown up around healthcare. It's very, very regulated. When you come in for a simple visit, you see me, a room, and maybe an x-ray. Behind the scenes, you've got electronic medical record documentation requirements, coding rules and audits, quality reporting programs, prior authorizations for imaging, therapy, injections, and medications. There's claim denials and appeals, compliance and security requirements. And then we have inflation, staff wages, rent, insurance supplies. Everything gets more expensive. So the practice's costs go up, but the Medicare physician payment has not tracked with that rise. If you tried to run a practice that was Medicare only, in many settings, you would need an insane amount of volume just to keep the lights on. And volume sounds harmless until you realize what that means. Shorter visits, less time to explain, less time to think, less flexibility for complex patients who need extra time. And I'll be blunt. Volume medicine is how you burn out physicians and staff, and it's how you create patients who feel unheard. Most physicians don't want to stop seeing Medicare patients, but practices do have to manage a payer mix to survive. That's not a moral statement, it's just basic arithmetic. So instead of saying no Medicare, many practices quietly ration access by limiting how many new Medicare patients they can take, or by having fewer open appointment slots for Medicare patients. And what you experience is longer waits to get in, longer waits for imaging, longer waits for elective surgery, longer waits for follow-up. So why can't you just pay more for more access? I hear this all the time. Wait, what? Patients will ask me, Doc, can I just pay extra to get in sooner? Can I pay above Medicare to get more access? In most normal Medicare situations, the answer is you can't. Here's why. If a physician accepts Medicare assignment for a covered service, the Medicare approved amount is considered the full payment, and you're only responsible for your standard cost sharing, like coinsurance and deductibles. If a physician is non-participating and does not accept assignment, Medicare still caps what can be charged with something called the limiting charge. In many cases, that cap is about 15% above the Medicare approved amount. So Medicare is basically designed to prevent balanced billing for covered physician services. That means you can't legally create a simple pay more, get faster access lane for covered care while still operating inside Medicare rules. The big exception is if a physician formally opts out of Medicare and uses private contracts. But that's not a casual move. During an opt-out period, Medicare doesn't pay for that physician's covered services, and private contracts have strict rules too. And one more nuance, you can pay out of pocket for services Medicare doesn't cover, but you generally can't pay extra for a covered visit just to buy VIP access. So this brings up the topic of concierge medicine. Most people, when they think of concierge medicine, think of, well, my doctor doesn't take insurance. I'm going to have to pay a very, very large fee in order to see that doctor, basically not use insurance at all. I want to introduce you to someone that I've known for over 20 years. This is Dr. Tony Aventa, and he's involved in a program that's kind of a hybrid concierge program in typical Medicare. It's a program of somewhat concierge type medicine where he can still take your Medicare. You can still use your Medicare. This has allowed him to contract his practice, and inadvertently, patients therefore have quicker appointment times. But I find this kind of an interesting model that they're using. It tends to draw pretty strong emotional reactions for people when their primary care doctor for their whole life changes to a different model where now they have to pay above and beyond what their Medicare covers. But they do provide services that Medicare doesn't cover, and that's the critical point here. Now, you cannot pay for access to a physician for Medicare. That's a violation of Medicare laws. But because of the way their practice is structured, they have to see fewer patients. And because of that, the doctor has more availability, more time, earlier open appointments to see their patients. And it really kind of rolls back the clock some 20 years ago when reimbursement really did adequately cover and allowed you to spend more time with patients and allowed you to see fewer patients and still make a reasonable living. But I want to introduce Dr. Aventa. I had a nice conversation with him. I hope you enjoy this. Okay. Tony, thank you for joining us today. I think I've known Tony for over 20 years. He is an internal medicine specialist and has a tremendous reputation. And I wanted to bring you here today to talk about what this new model that you have come up with or that you're using and how that can help Medicare patients. We so often hear about concierge medicine. People think, well, that means they don't take any insurance. But you all have come up with a method in which people can still use their Medicare. But they pay a small fee in order to be in your practice. Can you tell me how that works?
Sure. It may be helpful for me to kind of go over a little bit about the different types of models. That way we can kind of zero in on what I've decided to do. So at the very beginning, it's all about wanting to maintain that time in the patient-physician relationship. I want to be able to have the time to be able to take care of people. So one route might be what's called direct primary care. In that way, you may be having patients pay directly for services and not the physician not taking insurance in that case. In other cases, it might be something more like a retainer model. And that's where I think we get the topic of concierge medicine, which may be a little bit glitzy and kind of a luxury term. But at the end of the day, by not taking insurance and simply being on retainer, those physicians are able to have that time with their patients as well. In our model, what we decided was we still want our patients to be able to utilize the covered services through Medicare. We also take other insurances as well. We're able to stay in network that way, help our patients with their prior authorization issues, and be in network that way. For us, what that ends up doing is we add additional non-covered benefits, which is what our membership covers. I looked around the country. For myself, the MDVIP model worked out very well, so I'm an affiliate of MDVIP while also being able to be a partner in my own practice, utilizing all the resources that we have as a big group.
So a big thing with Medicare is that you can't charge an access fee. But I found it interesting that by using this model, you're able to see fewer patients, to have a more contracted practice, and probably practice the kind of medicine that maybe when you started your career, you're able to do, where you had plenty of time with patients. And indirectly, though, that gives people easier access to you. But that's completely within the rules. And I think that's what's interesting about this model. And can you talk about how the difference in like what your daily volume is now compared to what it had to be before?
Sure. And so, quite honestly, I've gone from about 1,600 patients that I cared for down to more like 400 patients at this point. And so by doing that, that allows me to still be able to have same day or next day availability for my patients. I'm able to spend time with people. In a lot of ways, it's taken me back 20 years in terms of my practice style. I always feel like I've had a priority of trying to really maintain that patient-physician relationship and being able to put that time into it. And what I was finding was that in our current economic environment, I just was having to see more and more people with less and less time. And so to not go down that pathway too much, I had to make some changes. And so I looked around at the different models, and the MDVIP model was the one that seemed to be able to allow me to be able to continue to take care of my Medicare patients, but also have the time to spend with them.
Have you had any negative reactions from your patients or patients from your own practice that say, wow, why do I have to pay extra now to see you?
Yeah. So that's an interesting topic that I want to touch base on because realistically, a lot of the ways that a patient might get into this model is because they haven't been able to develop a relationship with their physician. They haven't been able to spend that time with people. And so they go looking for a practice just like this. They're going to be able to say, I think that membership is worth the money to be able to have that extra time with my doctor, be able to get in effectively and, be able to be seen. So for my patients who I feel like they've been getting that type of relationship, it was a little bit of a challenge to be able to talk with them about why I was making the changes I was making. But I think the patients that have stayed with me, I think they've been very happy with the changes that we made.
Yeah, I mentioned to you before, I've seen some retired physicians who some of them were a little bit disgruntled about that, saying, why, I worked my whole career and took care of everyone under Medicare rules. But the thing they don't understand is we're facing these, well, they do understand it, but we're these intersecting lines of declining reimbursement and our costs have escalated tremendously. And at some point, those lines intersect. And today, compared to what you had to do 20 years ago, you probably have to see twice the volume just to cover the same amount of overhead and generate the same net revenue. So I find it interesting, and I've talked a lot on our channel about, I think mental health is probably the most neglected aspect of health, and it really even affects our joint replacement patients. Probably maybe the biggest risk factor of all that we see over other health and physical issues. But I would think that a model like this, because if you're seeing someone and for their diabetes or their hypertension, that's probably a pretty straightforward, relatively quick visit. But if it dives into, well, are we dealing with depression or anxiety? Suddenly that becomes an hour-long appointment. I think that's probably in more traditional models, maybe what sometimes gets put on the back burner or gets shelved for a later day. Can you talk about that at all?
Well, I think we can bring that into a broader topic also, in that, yes, mental health, I think at the primary care level is so important to be able to have that relationship over time. And so as we go forward, being able to have that time with patients to be able to dig into, ask additional questions that you weren't able to get to. In a lot of ways, my visits with my patients is their time and my time. We both have agendas that we want to cover. And so if by them bringing things into the office or by me asking additional questions and we're able to find out some of those things, the other nice thing is that we identify something. Gosh, I don't have to wait for 3 months to bring you back to see me. I'll see you next week. Whether that be in the mental health realm, whether it's following up on a medication we might talk about. So this particular model, I think, helps me to be able to spend that time with my patients, to be able to really care for them over the time.
And in your model, you all still process the claims for the patients, file the claims, so the patient doesn't have any extra administrative work just because it's still standard Medicare. And I assume this Medicare Advantage also
Yeah.
included in this.
So we'll take regular insurance, Medicare, Medicare Advantage. We'll take those different plans. But I need to be honest, it's not me just doing it myself. We
Okay.
have a huge team, as you mentioned. Expenses have gone up in physician practices. We have to have folks who help us on that prior authorization side of things. That's people that we need to compensate for their time and effort. We have care managers that help us. We have an amazing team under a physician-led team.
And we won't discuss pricing here, but when in talking to you earlier, I was really sort of impressed that it's not, in my view, not a terribly high amount of money. Now, granted, a lot of people are retired, can't afford it, but what this feels to me like we're taking things back 20 years when we could spend more time with patients. We didn't have to run this hamster wheel of really high volume all the time. What you're very involved in policy and advocacy for physicians and patients. Is there a systemic solution where this model could maybe work? But how do we make make this more available to more people?
Well, at the end of the day, I wish I had the answers for the healthcare industry overall. I don't know that I have that today, but what I do know is we need to be continuing to focus on the patient-physician relationship. When our patients are invested in their health, in some ways economically, they're going to be more interested in making those changes to help over the long term. So having that relationship over time, being able to focus on preventive health are all things that are so important that are going to help in our healthcare industry overall. If I can spend extra time, keep somebody out of the emergency department, maybe keep them from going into the hospital, that's a huge savings to the healthcare industry overall.
Can you talk about some of the services that Medicare doesn't typically provide that your program provides for patients?
So for us, for our membership fee, they'll get additional lab testing as well as biometric testing, all things that I wasn't able to do before because you're going to be paying out of pocket for all these different types of things. But when I bundle them under the membership fee, all of a sudden those things are covered. They allow me to take good care of my patients. And I don't want to say that I'm taking better care than other physicians. Other physicians have the same interest in caring for their patients. This allows me to have a little bit of extra time to be able to not only talk about things, educate people, but also follow up things.
And you've actually stayed in your current practice, correct? How have your other partners taken to this?
So currently in private practice, for us, we're an independent practice. That means that our physicians are owners in the practice, that we're helping to cover those costs of not only the office, but the office staff. And so as we go forward, it's been very challenging as each physician has come across this time in their career to make a decision about how they best want to take care of their patients. Some physicians have needed to leave our practice to go do that outside of our walls. And we've tried to bring that in here so that physicians that want to stay within our group now have that track of being able to care for those folks. And so we still have lots of physicians that still practice what I would consider volume-based care, still taking excellent care of their patients, but at the end of the day, utilizing resources in our clinic, whether it be our physician extenders, to help to manage that higher patient panel.
Yeah, we talked about in this video about how ultimately what happens is either doctors sometimes will change their payer mix, um, or they can stop taking Medicare altogether. But somehow it has to be managed. And one of the things also we see is a lot more mid-level involvement. The care can be provided at a lower cost. Are there any examples you can think of where in your new model you've been able to provide care that you might not have been able to in your old system?
I think that's a challenging one because we have always traditionally wanted to go above and beyond. But what that really ended up doing was I'm spending more time outside of my day, outside of that patient visit, where I'm documenting, making extra calls, doing prior authorization and work on those types of things. And as you can imagine, that can lead to more and more physician burnout the more time that we're investing outside of our office hours.
I know for me personally, one of the reasons I created this channel is, quite frankly, a little bit of burnout. There comes a point where you are having to churn through so many patients in a day, you don't get to spend the time with them. And one of the sort of goals of this channel is to educate patients because I've got, multiple hours of information and we've only scratched the surface and I don't have time to explain all that to them. And I feel like that's cutting them short. And so we all experience that regardless of the specialty. I think it's a little bit younger when you're a little more energetic and excited to be out there to churn through a lot of patients. But it's a different world. And what do you say to the patient said, Dr. Aventa, you've been my doctor my whole life, and now you're going to abandon me? How do you answer that question for them?
I appreciate your bringing it up. Number one, I want to applaud your efforts here because I think getting education and that material to our patients outside of office hours is just so important. because there's a really huge need for evidence-based information out there so that our patients can access it. So thank you. So the other thing I'd like to say is it was a very challenging transition for me. I had a lot of patients who completely understood what I was doing. I had other patients that were very concerned about the changes that were coming, but at no point did I want my patients to feel that they were getting abandoned and they weren't going to be able to see a medical physician. So in our practice, we allowed them to consider whether they wanted to go along on this journey with me as I'm making the changes to my practice, or if not, helping them to find other physicians that are continuing to take care of patients.
That's interesting. And, one of the things I tell people is said, well, you reach a point, age and energy level that you can't continue to practice that volume. So it's either quit or retire, and then you see no one. So they're all left out. But this at least gives some kind of avenue for patients to continue relationship, for you to practice in a healthy way and give people, quite frankly, the care they deserve. So,
Well, quite honestly, right now I feel like I'm back in that driver's seat of feeling like I'm working for my patients, having that relationship, and not just being in the room clicking buttons and trying to work for the insurance companies.
Yeah.
So it's made a big change in terms of how I perceive our relationship also.
You and I are of a similar age. It won't be that long that we're going to have Medicare. What are we going to do?
So as we go forward, there are probably more changes to be coming in Medicare. There may be answers that come along where Medicare understands that that longitudinal relationship is the best way to care for people. To be able to say it's not just based on the volume of people that a physician sees, it's not just based on that amount of time to pay for, but being able to compensate care for prevention and for taking care of people over time. My hope is that they'll see some models that really change.
Does Medicare not cover a lot of the preventative care that you're able to deliver to your patients now?
So there's different ways that Medicare can cover those types of things, annual wellness visits, but quite honestly, many of those things may be more administrative, even more so than having a physical exam with your physician. You may be aware that the Welcome to Medicare physical is really the only thing that when people turn 65, that's covered by Medicare in terms of actually having a hands-on exam. As we go forward, each year, the AWV, annual wellness visit, is covered to address preventive care issues. But that may not even cover the physician's time and in terms of spending time with their physical exam and taking care of the patient with their other medical conditions.
So what are some of the other benefits that your practice provides that Medicare doesn't cover that allows you to provide your patients now?
So there are a number of things that are included with the membership fee, including additional lab testing that they wouldn't have gotten it otherwise. It's helpful for me to take care of people from a preventive care standpoint, where I'm able to get additional lab testing on people that's going to help me predict cardiac disease or other issues that we need to address.
What are some specific examples of that? I'm just curious.
So Lp(a) is one of the ones. It's kind of a genetic lipoprotein marker to demonstrate people might be at higher risk when they wouldn't have known that otherwise. It's not one of the covered lipid profile parameters. And so I might be able to predict somebody might be at a 5 times higher risk for cardiovascular disease simply because of a blood test that is covered through their membership model. Other things that we're doing are biometrics, including things like monitoring how people are doing in comparison to their peers in terms of their physical conditioning, whether it be things that they can do aerobically, strength-wise. And so there's a lot of different things that go into it that are able to be identified through our website.
In the old model, how long was your average patient visit? And how long is that patient visit in the office now in this new model?
Well, one of the things we really tried to develop in my practice and a lot of the physicians that are in my independent practice is to be able to continue to have that time with people. But what I was finding was I was having to shorten those times down. So I might have 20 minutes for a follow-up visit, 30 minutes for a physical, where now I might spend an hour and a half for somebody's physical. I might have 30 minutes for a follow-up visit. So I can also adjust that time based on my patient's needs. So I definitely want to be sure that I get across that I think it's very important for us to continue to focus on the patient-physician relationship. That's what everything is built on. The more people that we have in the middle of that, whether it be insurers, whether it be Medicare or other regulations, the more challenging it is to take care of people. And so by going with a membership model, what I'm finding is that I'm once again simply working for my patients again. We're taking the time that we need to focus on their preventive care as well as their longitudinal care. This model, I think, is good even for young people because potentially we're making some great changes in health habits early where we can make a difference in the long term. And then otherwise, it can be very helpful for my older patients because now I have the time, if there are disease models, diseases that I need to address, and I have the time to do that with them, whether it be education, whether it be medication changes. We get to work together now.
Do you think this model will extend your career?
It will definitely extend my career.
In a time when access is still such a problem, there's an irony to that. But I think doctors will be able to work longer, and there'll be more primary care physicians for them to see.
Well, one of the things I'll say is I was not to that point. I think by spreading myself to doing advocacy for my patients outside of the office, whether with our medical society or TMA, I think that I was able to see more of that balance, but I wanted to make changes before I got to that point. Other physicians don't have that luxury. We're seeing burnout at high rates. We have health issues with our physicians, and people may be retiring early. And then you don't have a physician to take care of people at all. And I do want to stress the importance of that physician-led team, whether it be within the office and helping with all the items behind the scenes like prior authorizations and helping people to get their care for medicines and equipment, imaging studies, or whether it be us working hand in hand with our physician extenders like our PAs who are wonderful. But having that collaboration really helps us to take care of our patients.
If you had to go back and do all this over again, say go back 30 years, would you still choose this profession, this specialty?
So I don't think it's fair to look at my career because I've been so fortunate. When I was coming out of the Air Force, I was looking around at what I wanted to do, and it was take care of patients in an environment exactly like I found, where I have resources. Many times I can do same-day labs on my patients to get them the care they need. I have excellent partners that I get to collaborate with over time. And I'm in an independent practice model that allows me to be in charge of making those medical decisions. So I've been very fortunate. It just so happens that at this point in my career, it was time to bring my panel size down so that I can now focus on that time that I want to have available for my patients, be able for them to reach out to me. I no longer feel like I'm on call for my patients. I feel like I'm available to my patients. I know who they are. I'm ready to see them when they come in the office. And so it really has made a lot of changes. And I'm hoping that more and more physicians, as we go forward, can work within the healthcare structure to be able to have these relationships also.
And it's, I guess, probably freed up a lot of your time to do some of the advocacy work that you do.
It gives me extra time.
Yeah.
As you're aware, in Texas, on our legislative system, they come every 2 years to the Capitol to make legislation. It gives me more time to be able to focus on that, help our policymakers make good decisions for our patients.
This model, I think, is very impressive. It allows you to spend the kind of time you need with your patients. You're not rushed. You're not trying to churn through 30 patients in a morning and not give them the time they deserve. But it does come at a cost, and obviously not everyone can afford it. Is there any way in your mind that this sort of model could be scaled so it's more available to the rest of our Medicare population? Is it going to take more funding through Medicare? Are there maybe incentive-based or value-based incentives that can somehow come into play? Can you talk about that?
So at any point where a healthcare system is looking at supporting their physicians over time versus one particular procedure, one particular visit that they're doing, I think it's better longitudinally for our patients. So when we think about value-based care, we're moving in the right direction, but those are incentives that are coming 2 years later after being performed. It's not easy for a practice that might be going month to month on their margins to be able to take a look at that type of financial benefits. Currently, there's some things that are coming down. Medicare has advanced primary care models now. And so those are some potential answers as we go forward so that physicians can find ways to keep their doors open, not have to rush to see a large volume of patients, and develop these relationships where we can take care of people better over time.
In your experience in dealing with these legislative entities and dealing with healthcare policy, are there areas that you think could be targeted first as just massive wastes of money and time that we could make the system more efficient?
I don't know that I have an answer for that one, quite honestly. The one thing I will say is that we're all part of the problem. In some ways, how physicians care for patients, in some ways, how insurance gets paid for, all these different types of things are all part of it. So we're going to need a large legislative effort to come up with bigger solutions. But right now, unfortunately, I don't have those answers. One of the things that I often get asked is, what would I counsel my Medicare patients about? The number one thing, obviously, is this economically viable? Sometimes we need to consider the potential savings that might come from not having to go to an emergency department, not having a hospitalization, that there's some financial benefits of being in a model where you can get in to see your doctor the next day or same day, where you can reach out to them 24/7, whether something urgent comes up overnight or on the weekends. After that, do you have that relationship with your physician that you're going to see those benefits of that patient-physician relationship over time? Those are some of the things that I would say I'd get across.
So clearly, if every primary care doctor did what you're doing, we would have a problem. And do you think there should be some rules or regulations about who can go into this kind of practice model so that we still have ample doctors to provide? I mean, maybe is there a level of tenure or number of Medicare patients treated? Anything in your mind that you think there should be some guardrails around it?
I think that's one I can't really answer effectively.
Okay. Tony, thank you for joining us today. I really appreciate it. I find this model very, very interesting. It's probably going to create certainly some reactions on both sides of things, but I think it's pretty clear that the patients in this model are well taken care of. And ultimately, that's, I think, what matters the most. Again, I think we're on a collision course with Medicare and its reimbursement rates that's going to create an access problem for people down the road. This is one small solution to it, and hopefully one day we can come up with a more permanent one that will help everybody. So thank you again.
Thank you for your time. I really appreciate it.
So let's go back to the video. We're going to talk a little bit about Medicare Advantage. And yes, programs like MDVIP do take both Medicare and Medicare Advantage. The second bottleneck is if we layer on Medicare Advantage, and this is where patients get furious, and understandably, because Medicare Advantage can add 2 friction points: narrow networks, fewer doctors to choose from, prior authorizations, more hoops before you can get the test or treatment you need. So a patient will say, but you're listed in my plan, and the office says we're not in network, or we're not accepting that plan right now, or we need authorization first. And the patient thinks someone's lying. Usually it's not lying. It's just a system that is unbelievably complicated and constantly changing. Prior authorization is one of the biggest hidden drivers of delay. Every time we have to fight to get an MRI approved, that's time, staff time, physician time, patient time. And that time doesn't make anyone healthier. It's just friction. If you've ever wondered why it takes forever to get it scheduled, sometimes the delay isn't the MRI machine, it's the paperwork. So why not just opt out? Some doctors opt out of Medicare entirely. That triggers a big emotional response, and I get it. Personally, I don't blame physicians who do it, but I also want you to understand the trade-off. Opting out is not just, I don't feel like taking Medicare today. It's a formal decision with consequences, especially in a group practice: call coverage, partner coverage, and continuity of care of patients you took care of for years. I haven't opted out, but I also won't pretend I'm willing to run the kind of volume it takes to fund an entirely Medicare-only practice. So in the big picture of things, people are living longer. The Medicare population is growing. Demand is going up. And if we don't address the math and the administrative burden, The way the system solves itself is with rationing, not by saying the word rationing, but by making access slower. This episode isn't about asking anyone to feel sorry for doctors. It's about explaining why you can do everything right, have Medicare, choose a doctor who takes Medicare, and still hit a wall. If you're experiencing long waits or confusing plan rules, you're not crazy. The system is complicated and it's under pressure. So thank you for joining us today. I hope this explains a little bit about Medicare and the realities that we deal with on the healthcare side. I will be relying on Medicare myself in the future. And quite honestly, I think I'm going to have to lean on favors from people I know that are doctors that I've had relationships with to get me in and to get me access. But I worry for our Medicare beneficiaries in general, what this looks like in the future. If this helped you, please leave a comment, like, or subscribe. I'll see you next time.